I'm just going to say really quick, it's a pleasure and an honor to come after Dr. Coachman. It feels a little bit like a garage hair band coming after Metallica, but I'll take it. All right, so we're going to talk about autoimmune pancreatitis and cholangitis. I have to apologize this year that I don't have any fantastic videos of me cutting things, stopping bleeding. This is more of a cognitive type of a thought. So tomorrow, however, there will be a lot of videos. Okay, so no disclosures because the prednisone people aren't knocking down my door, I guess. So what are we going to talk about is the different types of what we generally say is autoimmune pancreatitis. And if you know anything about it, you know that there's a couple of types and the terminology can be confusing, and we're going to spend some time on that because I think a little bit of the devil of confusion is in those details. Regarding autoimmune cholangitis, in quotes, we're really talking about IgG-associated cholangiopathy to distinguish that from other cholestatic liver diseases. And we're going to briefly talk about treatment strategies. So what's the challenge? The first is terminology. You know, what do we call these diseases? That's been evolving. It's a somewhat difficult to diagnose disease, and it's rare. Its actual incidence and prevalence has not been well characterized, but it's rare. Out of curiosity, how many people have made a new diagnosis of autoimmune pancreatitis? Oh, very good. Quite a few. Okay. How many are taking care of more than one patient? How many are taking care of more than 5 patients? Besides Coachman and Ron. Okay. So, you know, it's somewhat rare. You know, I don't see it very often. When we do, we're very excited. But it's something that's still considered, even in a referral setting, somewhat rare. Part of the reason it's difficult to diagnose is that the criteria are somewhat hard to meet. A lot of the criteria were developed in Japan, where the practice patterns are a little bit different. For example, diagnostic pancreatogram is done routinely there, and here not so often. There's this distinction between suspicious for versus confirmed disease, and that can be a little confusing. In a disease that is, its hallmarks are histology, it's very difficult to get the histology. And so often we're left in a little bit of a guessing game. And perhaps most importantly, the first thing that I hope we think of when these patients present is not autoimmune pancreatitis. It's a cancer, right? And for the most part, there can be some anxiety, I think, if you're not sure what the patient has. And that's probably appropriate. It's difficult to treat in that although the vast majority respond to steroids, there is relapse, and how to manage relapse, how to maintain remission is a matter of expert opinion. There's really no data per se outside of series and consensus to guide us. And it's a relatively newly described disease. It was only first really described in the 1990s. So I graduated med school in 2005. When I was a second year, I was asked to give a talk in one of the sort of affiliated hospitals about causes of pancreatitis. And so I did what any good med student does, which is leave it to the last minute. So I looked on UpToDate, and I just basically copied and pasted the causes. And one of them was autoimmune pancreatitis. And I was like, all right, I'll just say autoimmune pancreatitis. And so I said at the talk, and 3 of the doctors, the attendings there said there's no such thing. So I thought that always kind of stuck with me. And I couldn't argue because I didn't know if there was a such thing or not. So it just kind of goes to show, though, how relatively newly described it is. And as I mentioned, the experience is not necessarily robust. It's often descriptive experience, expert consensus. So as in any disease, if you're not sure what to call it, make up something, right? And I think this is part of the problem, is that there's this alphabet soup of diseases that some people may mean one thing and another person means the other thing, and they're actually talking about the same thing. And so this is a little bit of a source of confusion. And there's been an evolution as we've gone away from calling it, for example, type 1 or type 2 autoimmune pancreatitis to some other terminology, which we'll get into. So to maybe skip to or talk about the cholangiopathy first, what are we talking about? So you heard some excellent talks in the earlier session about cholestatic liver disease. And there's a lot of diseases where, if depending on whose paper you read, that's what you would call autoimmune cholangitis. That's not what I'm talking about, okay? What I'm talking about is IgG4-associated cholangiopathy. And they're distinctly different, not only in their behavior, but in their treatment. So for example, PBC, that's AMA negative, that's often called autoimmune cholangitis, but that may not be steroid responsive. Overlap syndromes may be steroid responsive. So it's worth trying to tease that out. And as you heard from Dr. Choi, there may be some patients with PSC that are IgG4 positive. That doesn't mean that they have IgG4 associated cholangiopathy. So to take it one step backwards, there's a spectrum or a syndrome of IgG4 related diseases, of which IgG4 associated cholangiopathy is one. And so these have a common features of, it's an immune mediated spectrum of disease with shared features of pathology, namely the lymphoplasmacytic infiltrate. Often IgG4 stains are positive, and storiform fibrosis. And storiform just means it's in a whirlwind or whatever pattern, like a windmill. And the presentation is often with a pseudotumor, so you think there's a mass maybe causing jaundice or something like that. They tend to be steroid responsive, and multiple organs can be involved, the most common of which is the pancreas. And when we're dealing with extrapancreatic manifestations of IgG4-related disease, the bile duct is the most common manifestation, but there's throughout the body involvement, and I think in every specialty, there's maybe an organ that someone can talk about that's involved. The eyes, retroperitoneal fibrosis, the kidneys, mediastinal adenopathy, pneumonitis, inflammatory pseudotumors of the lungs. So then IgG4-associated cholangiopathy, which most recently has been abbreviated as IAC, and it'll probably change in a few years, is part of the spectrum of IgG4-related diseases. And it can have extrahepatic, it can have intrahepatic strictures, it can present with jaundice. It's often associated with AIP, autoimmune pancreatitis, hence the term autoimmune cholangiopancreatitis, as you may have heard. But it can occur alone without a pancreatic manifestation, and sometimes that's difficult to differentiate between a different cholestatic liver disease with a sclerosing cholangiopathy such as PSC, and it can also be difficult to distinguish it, and the key is to exclude underlying cholangiocarcinoma. Okay, so we'll move on then and talk about autoimmune pancreatitis. And I put that in quotes because when this syndrome was first described in the 90s, it was, people were kind of just noticing cool things and reporting them back in the days when I guess you could do that. And it was something, there was a common syndrome that didn't quite fit pancreas cancer, didn't quite fit the usual chronic pancreatitis that we think about when we make that diagnosis. And seemed like it was a systemic disorder. It seemed like there was an inflammatory component to it. And it seemed like there was steroid responsive. And so what we're talking about is really two diseases. And one of them is well-termed autoimmune pancreatitis. And the other is idiopathic duct-centric pancreatitis. So we'll kind of maybe tease that out a little bit. They're similar in kind of if you take a step back and think about how do these present. They present with a pseudotumor, often pancreatic enlargement with or without jaundice, in that they respond to steroids, and that pathologically there's a hallmark feature of lymphoplasmacytic infiltrate. So you can imagine being kind of in the good old days when Metallica was playing a lot in the 90s, and you have a series of Whipple specimens that come back without cancer, and there's inflammation, but it's not really chronic pancreatitis. It is in that there is a chronic inflammation, but it has a distinct type of fibrosis and a distinct type of inflammation. And when people start to put that together in the Mayo and in Japan, this syndrome of autoimmune pancreatitis came up. But as people were teasing these apart, it seemed like there were two distinct and separate diseases that just shared some of those common features. And so the first type, which is the most common type, and what we usually think about when we say the word autoimmune pancreatitis, is type 1, or just autoimmune pancreatitis, or what was used to be called, and some still do in the literature, called lymphoplasmacytic sclerosing Pancreatitis, just to add another, abbreviations to you. And this is really the pancreatic manifestation of IgG4-related disease, okay? And you may be familiar with the high-sort criteria. I think it's a useful clinical criteria. It applies most to type 1 pancreatitis. So high-sort is histology, characteristic imaging. In the States, it's mostly cross-sectional imaging. In Japan, it includes the characteristic pancreatogram, which I would say we rarely obtain diagnostically on purpose in this country. The serology, extrapancreatic organ involvement, and response to steroids. And response to steroids is actually pretty important as we're trying to sort out the difference between what we think may be autoimmune pancreatitis and a mass. So this is in distinction to type 2, or more properly called idiopathic duct-centric pancreatitis. And it's less common, it's harder to diagnose, and it has a different characteristic pathology, the gel lesion, the granulocytic epithelial lesion. And this is the one that's associated with comorbid inflammatory bowel disease and colitis. So let's kind of try to tease these apart. And this is really, what the heart of this talk really is trying to understand these three disorders. And I would consider them three separate. We talked about IgG4-associated cholangiopathy, and we're going to distinguish now autoimmune pancreatitis and IDCP. So the distinguishing features are the autoimmune pancreatitis is IgG4 associated. There's extrapancreatic involvement, and I gave you that list, so that's the other organs, the O. Relapse is clinically common after you stop steroids. In distinction, IDCP tends to be younger patients and is associated with IBD. Relapse is relatively uncommon. So let's kind of tease this a little bit further. Their presentation. Autoimmune pancreatitis presents mostly with an obstructive mass. So these are the ones that you think of, I think this may be a cancer. It looks a little funny on imaging. I've biopsied it and it's negative. Maybe there's some adenopathy in weird places. Maybe they have some proteinuria. Maybe they have some pericardial disease, as I think was on the recent board test that the fellows took. So these are the ones that you kind of think, okay, so maybe I want to think about an empiric course of steroids. These tend to be older patients, male predominant patients, as opposed to an IDCP. Most commonly described acute pancreatitis is the manifestation, and the younger patients associated with IBD. However, both of them can have very similar presentations, in terms of their clinical complaint. Although these can suggest a diagnosis, they're not pathognomonic. Serology is important, but it's not necessarily the end-all and be-all, and I think we all recognize this, right? A higher IgG4 is relatively sensitive and specific for autoimmune pancreatitis, but an elevated IgG4 in itself does not rule out pancreas cancer, and there was some series describing this, that there was a slightly elevated IgG4 in some patients that were confirmed to have pancreas cancer. That being said, the higher the level is, the more suggestive it is of an autoimmune pancreatitis. However, normal levels don't exclude the disease. IDCP is not associated with IgG4, and in fact, there's no specific serology, though there have been a number of markers that have been investigated that haven't really panned out, so it doesn't really help us in making that more difficult diagnosis. The imaging is hopefully something that your radiologist can help, but you have to be a little careful here because these findings are not something maybe that every radiologist is sensitive to. And so you want to have a favorite GI radiologist that you can go to if you have someone with a pancreatic or biliary presentation and you want to have a second look. I call her Barbara Cadell, but you want to find someone that you have a good relationship with and look at the images yourself. You just need to see a few of them until you kind of know what to recognize. So autoimmune pancreatitis, diffuse pancreatic parenchymal enlargement is the most common. The classic one that is often on boards is the sausage-shaped pancreas, and that's basically a big swollen pancreas without the normal contours. It's effaced. A rim is very useful and can be diagnostic. There can be a focal mass, and there's a little bit of a difference maybe that's subtle but useful when you see a mass on imaging and you're trying to distinguish autoimmune pancreatitis from a pancreas cancer. The one that I think is the most useful is the presence or absence of downstream atrophy. If you have a head mass and someone's jaundiced and their duct is dilated and their tail is atrophied, even if you biopsy the heck out of them and you're not getting cancer, you should be pretty suspicious that that's still a cancer, okay? I think it's maybe folly to call that patient probably autoimmune pancreatitis in the presence of atrophy and asymmetry of the gland and duct. In distinction, though, the ductal disease in autoimmune pancreatitis, there may be stricturing, but it's almost more like a beaded PSC type of a thing rather than a focal stricture and upstream dilation like you may see in pancreas cancer or chronic pancreatitis. So that pattern can be useful. And you don't necessarily need a pancreatogram to make that diagnosis, but that's part of the criteria in Japan. IDCP is a little bit different, tends to be more of a focal mass, tends to be diffuse enlargement. Interstitial pancreatitis without major extrapancreatic stranding seems to be one of the presentations that's kind of interesting. But again, it's a little less well characterized. The histology, they both have lymphoplasmacytic infiltrates. They both have a specific type of fibrotic pattern. The two differences are that the venules, there's an obliterative phlebitis in autoimmune pancreatitis, and there may be IgG4 staining. So on the left column, 3 out of 4 of those suggest a diagnosis of AIP. For IDCP, really the hallmark is the gel, the granulocytic epithelial lesion. These are polymorphonucleocytes. And I didn't show you any histology because I'm not a pathologist, and I'm not sure that I would know what to point out, but this is what you want to ask maybe your pathologist to look for if they're not familiar with these diseases. The gel is somewhat important because if you're considering this lesion in someone who doesn't have IBD, you really need that pathognomonic pathologic finding. So if it's not present, and this is important, if you don't have a gel, and a patient doesn't have IBD, you can't really make a diagnosis of IDCP. So a plug for EUS, because it's usually the answer. Why is it useful in this disease process? You can see the pancreas in a lot of detail, and we've gotten, I think, pretty good at looking at a mass or looking at a pancreatic lesion and getting kind of a gestalt of what am I looking at. It has not been well characterized in large series what the pathognomonic EUS finding is, but often what you'll see is a thickened bile duct within the pancreas. You'll see a diffuse hypoechoic enlargement, and then it allows us the opportunity to sample. Now that's probably most important to rule out malignancy, and in fact, FNA is not part of the consensus criteria for diagnosis. However, with developing and evolving core needle technology, sometimes we can make the diagnosis of autoimmune pancreatitis just based on a core, and that's very, very helpful if you can manage it. So I think it has a role. Its exact role in the algorithm is unclear, but in general, I think it's worth looking. And I can imagine that no one is going to make a diagnosis without an EUS to exclude a mass and get some tissue. This is kind of an interesting slide to me, talking about idiopathic pancreatitis. I'm sure all of you at some point have taken care of a patient, you don't know the cause of his pancreatitis, and you sent off an IgG4. And it turns out that every so often you may pick one up. In a Mayo series, about 4% of patients who were being investigated for idiopathic pancreatitis ended up with autoimmune pancreatitis. When you look at that data a little bit differently, if you look at a cohort of known autoimmune pancreatitis, at some point in their presentation, they met criteria for an acute bout of pancreatitis. So when do you want to think about that? A younger patient, if they have concomitant jaundice without necessarily a stone or stricture, if they have abnormal transaminases, obviously if there's other evidence of IgG4-related disease. The IgG4 itself is obviously useful, but if you remember earlier I said for IDCP, it's actually a common presentation, and IgG4 is not useful there. So the point is, just because you have an idiopathic patient with a negative IgG4, that doesn't mean that they don't have either AIP or IDCP. Response to steroids is important. So treatment is generally with prednisone or prednisolone for 4 weeks. There's this 2 to 4 week steroid trial that you may be familiar with if you have a doubt of diagnosis, primarily if you're not sure if this is autoimmune pancreatitis versus a pancreas cancer. You've done as much due diligence as you can to exclude a pancreas cancer, and you're kind of left with a little uncertainty, and you really want to meet that last criteria of response to treatment. I think it's reasonable to give 2 weeks of prednisone and then reimage. But you really have to follow these patients closely. I think the biology of pancreas cancer is not such that 2 to 4 weeks of delay in chemotherapy or surgery is going to alter anything, but there's a lot of anxiety surrounding that, so you have to just be very careful about reimaging. How you taper is not well characterized. Generally, you want to try to get patients off of steroids, but predictably, autoimmune pancreatitis, aka type 1 autoimmune pancreatitis, will relapse in a large proportion of patients. How you manage that is not well understood. You can restart steroids and try to taper them to the minimum effective dose. You can use immunomodulators similar to how you would manage a autoimmune hepatitis patient or an IBD patient. The immunology colleagues are big fans of rituximab, and there's emerging data. And I would say rituximab is probably your first line in someone who has a contraindication to a steroid use initially. So I put this into your syllabus and just kind of for you to peruse. This is the Mayo Clinic algorithm for treatment. I won't go into too much detail. It's just there for you. I'd encourage you to look at the international consensus guidelines that was published in the pancreas in 2011. I didn't put those up on purpose because it's mostly a research tool, in my opinion. There's tables and subtables and a lot of terms, but the cognitive aspect of it is there. And so hopefully that'll help you to think about this disease. Thank you very much.